fly into Kansas City a lot.
My life.
Is the airport to get in and out?
It is. It really is.
Alive? Okay. I think we'll go ahead and begin our last session here. Got one right here. That's yours. So if everybody wants to grab a seat, I think there are plenty out there right now. I appreciate everybody who is staying for our final session. But first of all, I want to thank also everyone who is here, who is participating today, that has served here as well as abroad. I know we wouldn't be here if it wasn't for your dedicated efforts. So the final session in this room is actually going to be in regards to healthcare and cybersecurity, in regards to threats to the military medical platforms. So it's one thing that hasn't been highlighted yet today. We've talked about education and various other topics recently, but now it actually has become one of the most targeted sectors for theft. As automated medical devices, as iPhones and so forth, and remote healthcare delivery become more commonplace in the battlefront, novel cyber threats have the potential to produce increased casualties. So the Department of Defense and industry medical program managers and cyber officials have a new challenge to overcome in the pursuit of timely and effective combat casualty care. So here today we have kind of a conglomerate of various different industry and DoD leaders and experts. They're going to help us discuss this today. So first of all, I want to kind of start this off is that did find a quote from the former FBI Director Mueller in 2012 that there are only two types of companies, those that have been hacked and those that will be. And even they are converging into one category, and it's companies that have been hacked and will be hacked again. So I think that also applies to healthcare. So I think Admiral Rogers was right on point this morning. This is a unique opportunity we have here with industry, government, and academia all partnering together. I think we represent that amongst this table right here. And how can we improve this country's cybersecurity? So briefly, just want one line about myself, and I'm going to let them extrapolate further about themselves. But I'm the Chief Medical Information Officer at GR Health, and I'm an internist or internal medicine physician by trade. So I've been one of the physician leads in the design implementation of our EHR and other information systems here. Next up, we have Dr. Tim Bentley. He's part of the Future Naval Capacity and Force Health Protection, and he's the Deputy of the Office of Naval Research. Some areas of concentration include decreasing the logistical burden of forward medical operations, mitigation and prevention of combat-related illness and injury, and providing cutting-edge medical applications for our Navy and Marine Corps warfighters on land, sea, and in air. So I'm going to actually get you to briefly talk about that for a couple minutes.
Thank you very much. Actually, that would be quite a promotion for me if I was the Deputy of the Office of Naval Research. I'm the Force Health Protection Deputy. And although I find that a glorified position, it's not the same as the Deputy for ONR. ONR is the funding organization, the research support organization for the Navy and Marine Corps. And we fund from basic to early applied research across the continuum of technologies that the Navy and Marine Corps are interested in. And one part, of course, is C4ISR, or information management, communication, and therefore cybersecurity is a very big issue. However, I'm from the component within ONR that develops medical care advances for sailors and Marines. And of course, if it works on a sailor and Marine, it's our intention that it would also work on airmen, soldiers, Coast Guardmen, and usually in the civilian environment. And since we work primarily before hospital or pre-hospital care, we have several unusual, I think, or significant challenges in terms of cybersecurity of medical data. We are obviously deployed, or our sailors and Marines are deployed on ships, and they're deployed inland. They're spread out far distances and always moving various places. So we can't have stable wired networks. That means that at in the operational forces, medical information needs to move across ad hoc networks and wireless networks potentially. And that's a challenge There's not much bandwidth out there, and what bandwidth is available is always consumed by the operational forces. Medical gets a share of bandwidth when it's necessary, but it's very difficult. So we have to think about how we protect our information while moving it across such sort of rough terrain, if you will. Another point I wanted to make is that even the fixed facilities are spread around the world. DOD is being a leader, I think, in electronic health records, although that's debatable. We make big strides forward and then things don't go as well as we might have hoped. But eventually we'll have all our medical care hooked up from the point of injury all the way back through care and either return to duty or discharge from the service, and then transfer the information to the VA. A thing I'm particularly interested in and concerned with in terms of cybersecurity is something that we call the automated critical care system. It's essentially an intensive care unit in a small box that fits underneath the stretcher. A seriously injured casualty goes on the stretcher. The ACCS, Automated Critical Care System, monitors the casualty's status and then provides him autonomously with therapies like giving him more fluid or pain medication or sedation. That all needs to be controlled, obviously, on board the computers, but the caregiver, the intention is for the caregiver to be able to move away. Initially, just moving away several feet. If you're on an aircraft or on a ship or even ashore, you may be able to take care of multiple patients at the same time. So you're communicating from this device to a handheld system. And over time, this system is intended to move farther and farther away from the caregiver so that we get into a case where the ACCS with this casualty may get put onto an autonomous vehicle like a helicopter that can fly itself or a ground vehicle that can move by itself, essentially a drone. And as the drone moves away from the caregiver, the distances over which control takes place become longer, and that link becomes yet more vital because there's no one that can walk to the casualty and intervene. And finally, we need to be concerned with hierarchical passing of who's in control. And a big risk, of course, is that the data gets lost or the data gets hacked. And there's hacking that may take place in two ways, sort of a passive hacking where the enemy might understand what's happening with our casualties to understand how effective their weapons are or their attacks are or our force strength. And the alternative might be, and it's even worse, they might get involved in the care. And instead of leaving the drug level at where it ought to be, they could turn it to 11 and actually intervene in such a way that they could, as Dr. Fallow said, increase casualty, the number of casualties. And it might be very hard to determine what happened there forensically. So there's a lot of interest in this topic area. And from my perspective, we haven't looked into it very much. We've looked into cybersecurity, of course, and communications a lot, but not very much in this sort of tactical casualty care arena.
Okay. Next up, we have Andrew Sargent. He's the Director of Product Management, Interoperability, and Product Security at Philips Healthcare. His former role at Philips was as the Privacy Officer for Patient Care and Clinical Informatics. He also has 23 years of previous experience in commercial banking and 8 years as a CIO/CISO or security officer. I'll let you further talk about that.
Yeah, I'm the lucky guy that's been in 2 of the critical infrastructure industries that's on the panel today. So, and I think that gives me a little bit of a unique perspective. But from a healthcare perspective, I've spent, and just to give you a little bit of a taste, the FDA just recently, in fact, the last 2 days in Washington, D.C., had a cybersecurity meeting, which I was fortunate to be able to attend to and then flew in last night. So this is clearly an area that has a lot of interest from the industry and also from the not only the private sector, but also the public sector from a healthcare perspective. And the government. So, and we also consider this to be a significant area of interest from the national security area as well. So, to echo one of the previous panel's comments, and I can't remember who it was specifically, a lot of this comes down to security hygiene. This is very basic block and tackling that a lot of healthcare and a lot of not only healthcare but banking and other sectors are missing out on today. So, I think if we can help to mitigate and have those discussions on how to enforce basic information or cybersecurity to provide the information assurance that these devices need as they go into the areas of mission on the front line and others. Then we can start to assure that our devices will operate as they're supposed to, and then pass information on to the medical records, who's on my far right, so that we have that continuous patient record from the point of injury through to when they are no longer a part of the military but have transitioned into civilian life. So.
Thank you. Next, we have Lieutenant Colonel Jennifer Hatsveld, who is a research scientist in the U.S. Air Force. She entered the Air Force Nurse Corps in 1995, first as a clinical nurse in California, South Korea, and Italy, and later managing population health efforts at Randolph Air Force Base in Texas. She completed her PhD in nursing in 2009 at Johns Hopkins University, where she studied disparities in health outcomes among active duty Air Force members by race/ethnicity, gender, and rank. Lieutenant Colonel Hatsveld served as the Director for Clinical Research at the Travis Air Force Base Clinical Investigation Facility, focusing her research efforts on military-specific topics, including combat casualty care and understanding pain management during patient transport. She's currently managing the Department of Defense Joint and Route Care Research Portfolio within the Defense Medical Research and Development Program at Fort Detrick, Maryland, and chairs joint working groups to develop virtual critical care and unmanned patient transport. So kind of in collaboration, it seems, with Tim Bentley here.
Yes, thank you. Tim and I work pretty closely together. He's on the Navy side, and then I get to work more at the joint level, which is exciting because I get to see what's happening in each of the services as we organize, train, and equip, but then also focus on sort of the application of that in the battlefield, battle space, which is a joint environment. You know, I think when I was asked to consider to come, I was excited about it because I think we talk a lot about cybersecurity and how important that is. And we talk about patient privacy and how important it is to protect information. But we don't really talk much about how that intersects, and particularly how that intersects in combat casualty care. And Tim mentioned some of the challenges with combat casualty care and how we transmit data, how we protect that, how we keep things safe from the enemy, so operational security. And then Andrew talked about sort of the cybersecurity for medical devices. And those are both important. But when we put them together, it's not a 1+1 thing. It's now suddenly a sort of exponential thing. It's unfortunate synergy. And I think if we start to think about it as an example of transporting a patient in theater on a helicopter and we want to transmit some information about that patient, right now, the way we do it is through a radio, which is a secure system, so a classified system, which goes to a secure area at the receiving facility, which is in a separate tent or a separate office that's locked and nobody gets in there. So all the nurses, doctors, everybody's caring for patients outside of that. Inside the Tactical Operations Center, the TOC, they get that information, they write it on a piece of paper, they leave, they go track down Dr. So-and-so and hand them the piece of paper and say, you have 2 patients that are urgent surgical that should arrive in about 15 minutes. We know nothing about what that patient may or may not be. We don't know what's going to happen, and all of that other information is on the classified system. All the medical stuff is on the unclassified side, and we want it that way because we want to be able to give that unclassified information forward to the VA or whoever. But now there's really no good way to integrate that information or that process, and it's not just who's coming and how quickly they're coming, but let's start to add in a few more things like vital signs and all of these other things. And the problem is that we could probably do some workarounds to make that happen. But if we could build that in from the beginning, so as these medical devices are being developed, that it's part of the conversation and part of the things that are being considered. And as we start to teach people how to work with cybersecurity, that we also start to talk about patient privacy and what that looks like and how we can integrate those. I think that's probably the most important part. And then we get the good part of synergy, where we're starting to build those things into medical devices and think about cybersecurity at the very beginning and not trying to fix it after the fact, which is kind of where we are at the moment. So that's my passion. I think Tim mentioned telemedicine or transmitting data, and that's an important one. There's teleconsultation, where we're trying to interface with another provider to ask them help or get input. There's also remotely piloted vehicles and transporting patients that way. All of these elements have specific vulnerabilities that we need to be prepared for in a cybersecurity area that have an impact on patient care. So, thanks.
Okay, thank you. Next, we have Jeanette Little. She received her undergraduate degree from Hope College and her master's degree here at the Medical College of Georgia. She's worked in the field of telemedicine and e-health for over 16 years and has been focused on mobile health initiatives since 2008. In 2011, she was a part of a team that received one of the 2010 Army's Greatest Invention Awards for the MCare project. She also received the G. Ruffus Sessions Award for Excellence in Mobile Health in 2010. Currently, Ms. Little serves as the director of the Mobile Health Innovation Center at the Telemedicine and Advanced Technology Research Center, TARTRIC, here at Fort Gordon. The Mobile Health Innovation Center serves as a center of excellence for evaluating mobile health technologies by providing subject matter expertise in a unique laboratory environment for intramural and extramural research activities. I'm going to get her to further talk about that.
Well, good afternoon. At Fort Gordon, we represent a group that's focused on technology and how to insert it into the healthcare process in partnership with our colleagues in the Cyber Command that are dealing with the communication networks. Can you hear me better now? No. Any better? Okay. So we work to look at how to take those technologies that are useful to solve a clinical problem, whether it is in theater, but also into the outreach into the home and life space of the patient between the clinical encounters. So we're dealing with the spectrum of everything from the operational environment that Colonel Hatsveld has just spoken about, all the way down to how do we do the bring your own device model and ensure that that data exchange that's coming in is respectful of the patient's privacy and is also not going to produce a hazard to our government systems. So we are looking at the full spectrum of that, and we enjoy a great partnership and really enjoy being here at Fort Gordon.
Okay. And last but not least, at the end, we have Gary Johnson, who is the Vice President of Security and Enterprise Services at Cerner Corporation. And you'll notice that two of our security representatives here are actually two of our representatives of our collaborative partners at GR Health. We have a unique relationship with both Philips and Cerner. He joined Cerner in 2005 as a Director of Corporate Systems Management. In his security role, he has rolled out a complete risk-based security program comprised of architecture, vulnerability and threat management, incident response, governance, risk and compliance, security operations, and physical security. He has 20-plus years of experience in information processing and telecommunications. Prior to joining Cerner, he was Vice President of Engineering and Operations at Birch Telecom. In addition to his work experience, he also served for 4 years in the U.S. Army Signal Corps as a communications technical controller, with 1 year in South Korea and 3 years as a supervisor at the East Coast Telecommunications Center at Fort Detrick in Maryland. He studied microcomputer information systems management at Potomac College. And I'll let you talk a little bit about Cerner.
That was a little more than I expected here, but I came into the airport, drove out here, and things look a lot the same as they did in 1986. The last time I was here was actually in 98. I got to walk the Augusta National on Sunday during the Masters, watching Mark O'Meara win, so that was a great experience. But over the almost 30 years since I was here in school at Fort Gordon, it really didn't look that much different. So that was actually a nice experience. So I'm sitting here at this table, and I really feel like I belong at like the kids' table. Some really highly credentialed, experienced folks here, and I'm honored to be part of the panel. My role at Cerner it's changed quite a few times over the last almost 10 years. The last 3 years I've been running the security program. I'm not a security guy. I don't like to be, honestly, to be referred to as a security guy. I'm a technology geek. I mean, I like technology. I like to say that I was kind of in the wrong place at the wrong time 3 years ago. We recognized that we needed to make a change as a company from being more, I think I heard earlier in one of the earlier sessions, we're talking about compliance. So we were more compliance driven at that time, and our clients, honestly, have helped push us in a much more, risk-based security program perspective. So I've been working the last 3 years, myself and my team, building that type of program. We've made a tremendous amount of progress, and we spent a lot of time with our clients talking about security and collaborating and trying to be as transparent as possible. And I think that's the best way that we can all work together to improve, cybersecurity and it really seems like I'm pushing that boulder up the hill, right? And the next day I come back to work and the boulder is back down at the bottom. So working together is really the only way that we're all going to be able to get that boulder to the top.
Okay. Well, one of the things that I was kind of, we had a brief discussion at lunch about a couple of topics, and one of the things kind of caught my ear, and it was discussion about what does telemedicine mean today, and should it even be called telemedicine anymore? And the reason why I was thinking about that is because we here at GR Health now have a new initiative in regards to telemedicine with our acute access hospitals in the periphery in regards to EICUs and so forth. But gone are the days where telemedicine is picking up the phone and getting a phone consult. It's just quite transformed from there. I don't know if anybody wanted to kind of take that topic. I'll open that up for the field right here.
Well, I think in some regards, the tele connotation has disappeared in some things. We don't talk about it as teleradiology anymore. That is just radiology, but the practice of teleradiology was very much distinctly separate for quite a few years. And so as processes of inserting technology into healthcare delivery mature, the teleconsultation appendage to the name tends to disappear. But there are many things that are not nearly as mature as teleradiology is in the healthcare industry, and those are the things that we're focused on working with these days. I think a term we're hearing a lot more than telemedicine is e-health, and that is certainly more of a terminology that we're using. However, on the other side of the spectrum, the telemedicine industry is going through a transformation in that now all of a sudden things that have always been challenging for providers to receive reimbursement for are suddenly, that glass ceiling has begun to be broken. And there are things now in the real-time world that now can be reimbursed for. And so you're getting a number of providers and a number of people in the medical industry engaging in this process that weren't formerly engaged. And what we're beginning to see when we go to our national conferences and have discussions is some fundamental principles of security and privacy are not at all part of the lexicon of this new breed of people entering the industry. So we're kind of having to hit the rewind button back to a decade and re-educating everyone on how important all of those things are in the process. Because there is some new excitement into to capturing that workload that wasn't there when they couldn't bill for it.
Okay.
So I was the one that claimed that telemedicine is a word that should not be used, and it's partly because the way the military works, in order for us to invest in advanced development and purchasing new technology, is there needs to be an identified requirement. And so the question is, do we have a requirement for telemedicine? And the people that write the requirements document said, we already have telemedicine. You get on the radio and you call ahead and you talk to them, and that's telemedicine. And so there's no reason to have telemedicine. And so I have tried, it's funny because you fight battles that you feel like you shouldn't be fighting, but I have tried to fight this battle, and I've decided that it's the word that's the problem. And it's partly because it's so broad. It could mean anything from get on the radio and call somebody, to walk down the hallway, go grab Dr. So-and-so and get him to come back to the radio and talk to him, versus real-time streaming, high-definition video that interfaces with the patient and does some kind of intervention. And when you have that broad of a term, it's no longer useful. So I think we kind of have to be a little bit more specific about what we mean by telemedicine. What does that look like? What do you mean by that? What type of data? I think on the clinician side, we need to be a little bit more thoughtful about what we mean. What is it that you need? Do you need real-time, high-definition streaming video, or do you not? Do you need blood pressure and pulse, and do you need that every 30 seconds, or is every 5 minutes okay? What is it that you actually need? What is it that actually improves patient outcome? And honestly, I don't think we know that yet. And so we need to do a little bit of our own homework as clinicians to find out what it is that makes a difference. What is it that we really need? We can't just say we need telemedicine, because that's not specific enough.
Hey, Ms. Little, I know you were actually doing a little research in regards to different ways to interact with patients, maybe different ways of documentation and so forth. You want to speak on that? I think it really points to bandwidth, what we need, and how we interact.
Yeah, we've done a lot of work for directly engaging patients, particularly a subpopulation of wounded warriors that are going home and are trying to maintain their continuum of care and continue to recover, hopefully to get back to active duty. And the minute they leave the controlled environment of the healthcare setting, then all of a sudden all those issues of perhaps cognitive function, if they have a brain injury or so forth, come into play of how many times a day am I supposed to take that medication? When is my next appointment, and so forth. And so we've done a lot to do the outreach to those communities to see how we can leverage mobile technologies and still maintain that secure connection to keep the patient engaged, to keep them on track without violating any kind of privacy or security issues. And you know, on the converse of that, there's the monitoring in the operational environment that Colonel Hatsveld is speaking about. And is that a wearable sensor that's in their uniform? Is that a device that you put on? And how is that information being pushed back? And is it over the secure channels or the unsecure channels? And so all of those things and the communication there are part of what we struggle with every day. How frequently? What's the level of security? What's the detriment if it is compromised? Those are all issues that we tackle every day.
So that kind of is a nice segue into security as far as in transmission of data. I know we struggle with that as in the civilian sector, but kind of going towards Mr. Sargent and Johnson, I know Cerner has a huge remote hosting center in Kansas City. How would you reflect on kind of the comments that were made here, of protection of just transmission of data, but maybe even protection of transmission of data in the battlefield? Maybe you have a remote transport vehicle that's carrying a patient back. How do you envision protecting even just the who's driving the vehicle, the transmission of data, and so forth?
Yeah,
Loaded question.
Yeah, so I don't think we have answers to everything yet, right? Security is a largely 30-year-old, maybe even older, but at least 30-year-old kind of mindset. So the way we protect data and provide security today is really not a lot different than it was when I started in IT. But we're still using firewalls and we use intrusion prevention solutions and intrusion detection solutions, and those, while those technologies have advanced, they're not doing things exactly the same way, but essentially they're still looking at the traffic on the network and making decisions about what to do with it, right? And it's all about trust. So building those trust relationships from the field, from the transportation unit back to, where you're storing your data. And that's key to how do you keep that data safe while it's in the air. One of the things that Cerner has done, it doesn't translate directly to mobile, but we built our own fiber network across the United States. We had some selfish reasons, right? Cost, for sure. It turned out to be a lot less expensive to have your own backhaul rather than leasing that from AT&T or MCI or whoever. So that was one reason. Second reason, we could guarantee the privacy, aspects of that data because we managed almost from start to finish. So once it enters our network and to when it gets back to Kansas City, we have control over that data. So we have a chain of custody mindset logically on that data. Now, the piece that's missing, we can't really control, is that connection from our network to the hospital, to the client, whether it's mobile, whether it's wired, satellite, any sort of. So you have to put other controls in place, right? And that's where your encryption and firewalls and other technologies come into place.
And Mr. Sargent, I don't know if you can comment even further. What I would be looking at actually as well as, I think we're all going to some sort of mobile device as far as monitoring the patient and so forth. What do you envision as far as methodology to prevent theft from wireless devices?
So there's a couple things to talk about here. So I'll talk about the monitoring in theater or monitoring wherever first, because I think we need to answer that question. Because once you acquire the data, then you can display the data. So it's just a matter of user interface at that point, whether it's a PC or a smart device. So, so the acquisition of the data, one of the things that we're doing at Philips is, and this is the interoperability part of my job, is to be able to support our devices on any network. So whether that be wired, wireless, or cellular. So that's not our area. The network is not our area of competency. So, what we are is very good at creating devices and around monitoring patients, reporting on the patient condition, and then sending that data electronically to the medical record. So that's where we find our competency. So to go back to Tim's point earlier, we look at sharing that, and I realize that's a very small piece of the infrastructure. But typically what you find is patient monitoring data is pretty small from a bandwidth requirement. So it doesn't take up a lot of space. Where you get into the space requirements and the infrastructure is once you get to the central monitoring system. So, and then that's where, to go to the remote monitoring spaces, that's where everything starts to get distributed. So from a mobility perspective, we've talked about now the device mobility, which can be attached to the patient wherever they are. And I definitely, Philips has a number of areas of research that are focused on medical body area networks so that you can embed in the uniform or other places. But as part of that then is communicating to a device that's on the soldier, so that then is sent across that shared infrastructure that's built in the battlefield and reported. So once you get it to the central monitoring system, then that's where you start to have the data distribution to those different consumers of that data. So the nurses, the physicians, to the EMR. And we don't really have a preference today whether it's mobile or fixed. So we support both Android and Apple devices from a monitoring perspective. And you can view the changes in the patient condition. You can create customized patient lists, so from a mobile perspective or web or from a fixed central station. So, and then to go to the next tier where you have fewer resources or you have higher acuity patients but don't have the resources in field to be able to provide those care settings, where you have intensivists that are maybe centrally located, then we have the capability to have that data acquisition across, for the lab data, if there's lab values or medication administration, and it layers on top of that the ability to make decisions So for the changes in the patient condition, so you can proactively apply treatment. So we're a partner, but we don't look at us as any one piece. We're just one piece of the pie. So
one other, you threw up your iPhone. One of the things that we've been working on over the last couple of years is to try to take your typical desktop applications that would consume from Cerner and put them on mobile devices. And naturally, big concern is privacy, right? These things are easy to lose. I lose my phone a couple times a year. So I'm sure that I'm not the Lone Ranger when it comes to that. So the way we built the applications is that the data is not, it's not resident on your device. So once your session time's out, if you were to lose your phone or you log out or you terminate the session in some fashion, the data is essentially sucked back off of your device. So the real risk is honestly where most security risks are is still internal, right? So that end user that has that device, because again, right, we get back to trust. How do you know who's on the end of any device connecting to your environment, and can you trust them, right? So identity management is extremely important, regardless of how you connect.
Okay. I know this is going to be a broad question. I want to open this up to whoever would like to answer. I know we briefly talked about having some sort of one continuum of care from point of injury or point of triage to discharge to even in the military, discharge into civilian life as well. What do you see are some of the barriers currently? It could either be government policy or technological that are apparent right now.
If you talk about the whole continuum of care, we have a very hard time collecting data at the battlefront. And although we are talking about putting devices into the uniform and collecting data there, or having the medic or corpsman have a device that he could hook up to the casualty, those don't exist at this point. So there's a big gap between the point of injury and some farther back medical facility. And then I think there's the general concern or challenge of just hooking medical records together that everybody's facing. I know Cerner's working on that, and it sounds like Philips is facilitating that connection, but somehow getting that all linked together. I'm not sure if it's Cerner or not, but some company has recently gotten a very large contract to start on the new electronic health record for the military, and they don't see that being deployed for 5 or 7 or 9 years, sort of depending on what stage you're talking about. So there's just a lot of maybe fiscal and structural challenges. Nothing that can't be overcome, but some big challenges.
I think there aren't a lot of technology limitations. I think it's feasible technologically. It's our policies and how comfortable we are with risk. And I think there's a lot of, we start to think about the legal implications about clinical documentation in a trauma bay during transport and all of these things. What happens if the data disappear or something happens to that electronic record or the transmission of it, and then who's responsible, and what happens if there's a bad outcome, and so we start to get very conservative in our thinking when it comes to documenting clinical care. And I think the other piece too that we haven't exactly fixed or addressed yet is how do we document care in a pretty dynamic environment like a emergency room or trauma bay. And so right now we're doing it on paper, and in talking with some of my colleagues and the different services, it's sort of an angst that why is that still on paper? Why can we not get it on electronic records? And then, but if you go to any trauma bay, you go to Baltimore Shock Trauma, to Cincinnati, any of these, they're documenting on paper too, because it's just such a dynamic environment that there's so much going on, and it's difficult to capture that on a computer screen, either with a mouse or a tablet or whatever. And so I think although the technology I don't think is the problem, I think it's the workflow and the work process that we haven't worked out. So there's more that needs to get done into how we capture that.
I think that where clients, whether it's the government or individual hospitals, can help drive a better interaction, it's to force Cerner, force our competitors to work better together, right? Because, it's appalling to me, right? If something happens, on my way to the airport, I leave here and I have to go to the hospital here, no one, if I go to this one, it's a Cerner hospital, maybe a better experience, but I may not be coming to this one. I might go to a different one that's not a Cerner hospital and doesn't have access. They don't have access to my health records. So, that in this 2014 should not be an issue. It's definitely not a technology problem. It's absolutely a company fear of me knowing too much about their stuff and vice versa, right? It's a company policy problem.
Okay. So you're about to make a comment. Hold off.
I think it's been covered. Thank you.
Okay. What I'm going to do, since we're about 5 minutes after 4, I know we're already running late, I wanted to actually open some questions up to the audience unless anybody here wanted to make an additional comment about another subject. So please come with your questions.
I'm retired Colonel Marietta Beck from the Army, and one of the questions that I have that was discussed during lunchtime with some of my associates is how's the Affordable Care Act and the new implementation of the electronic record and the fact that people can go to CVS and all these other places. I mean, we've discussed a lot with the military, I understand that, but we were really concerned, and some of the people are really concerned about how the security of these records when you go get a shot over at CVS or Doc in the Box, and how's that going to be with the implementation of integrated records?
I think you're going to be the expert on that, I guess.
Again, right, that's still a little bit of what I just talked about, right, is getting CVS, Walgreens, the small 1 or 2 physician office to all interconnect. Our CEO has been talking about the network, and what he really means is having, you as the patient and all the way through, that whatever point of care, wherever you happen to get your care at any point in time, all tied together. I mean, that's his ultimate vision, and we've been doing as much as we can in that space to try and get. We have a lot of different agreements with a lot of our competitors. We're beginning to share information, but it's a lot slower than we would all like it to be as patients, for sure. It's that fear, from a business perspective. Am I suddenly giving away the secrets to my success? How am I going to get compensated for this, right? This is free work, essentially, right? And those are all things that we struggle with, not just Cerner, but our competitors, partners, et cetera. I think the government could certainly help, truly mandating some of those relationships, and not how I would envision it would turn out, some watered down version that a group of lawyers can find a way around.
So I have a couple of thoughts. One of them is if something bad happens, then good. It forces us to deal with this issue. We can't just pretend it won't happen. So in a way, we can't say we're not going to move forward and have this electronic health record that can be accessible, because we need that information. And when you think about it, and being in the military, how we had CHCS, so we had a, electronic health record of some sort from early on. how helpful it was to know that that patient, we knew what their, their CBC was a few years ago at Fort X, even though we're now at Fort Y, because we could see it and we could tell that that had been done, and okay, that hemoglobin, although it's low, is not unusual for that patient, or that they've actually had their, tetanus shot, and we can see that there's documentation. Even though the patient can't remember it, we can see documentation's there and we can verify it. So I think there is good that comes from the electronic health record and from mandating it, because we can't stay with sort of these silos or paper records that nobody can keep track of. So we have to move forward. And yes, there will probably be bad outcomes or, data breaches that happen, but it'll force us to do it better.
And I do think with the Affordable Care Act, specifically, High-Tech Act that mandated meaningful use and so forth, with every stage of meaningful use, you do have a new security level you've got to reach in order to attest for that stage. Now the question is well, all of the practices out there that are not meeting those certain stages of meaningful use, all the pharmacies that really aren't under that umbrella yet, that sort of thing. So I think that is something that's a great point, that we have this balance of, well, we need to share data, to your point, but also secure that same data. So we had another question.
All right. My question, Bill Lawless, Payne College, Augusta, Georgia. My question deals with the link ability between health records and financial information. How secure is that? Is there a link that has been made, or is it strictly in the financial records office? So if I got a hold of financial records, could I also get a hold of, if I were a criminal, could I also get a hold of the medical information, or how linked are they, and how vulnerable have they been? What is the data that's available on that? Thank you.
That's a broad question. So, and Andrew can probably help out a little bit here since he's got the banking background. But so currently, if you're a crook and you want to steal data, and you're typically doing it for the same reason that we're in business. You're doing it for the money. Let's say I steal 10,000 credit card numbers or 100,000 credit card numbers or 1 million or whatever. I can monetize that pretty quickly, but I'm not going to get a whole lot of money for that. I'm going to get 25 cents, 50 cents. And that's because banking has done a pretty good job squashing fraud, in spite of the breach of the day that we see, right? And I don't know how many. I just got my 3rd debit card of the year, because of Home Depot this time, but it was, I don't even know who it was the time before.
Soon to be Staples.
Soon to be Staples, yeah. But a medical record, right? There's a lot of rich data in a medical record. So depending on which report you believe, you could sell a medical record for $10 up to $50. So now, if we think about the CHS breach that happened a few months ago, where 4.5 million records were compromised, $10 times 4.5 million. If I can monetize that pretty quickly at $10, I'm going to spend a lot of time and effort and money and my technology trying to steal that data. So I think part of your question was, are the two connected? That really depends. At Cerner, it's not. The medical records are stored in different databases, but, can you theoretically, compromise one database and jump to another? Certainly. I mean, hackers, that's all they do, right? I mean, that's their job. So they focus all of their efforts on looking for one problem in your network, right? And if you're the security guy at a hospital or anywhere, you got to plug all the holes. And there's a new vulnerability that is classified as a 10, right, whatever that means, almost every day, every single day. So on this side of the fence, it's a daunting effort to protect data, right? So, can data be compromised across from one database to the next, from one server to the next? Absolutely. We have to do things to protect against that, right? You have to implement responsible security technology and practices. You have to have visibility, right? You have to know what's going on inside of the environment. We've implemented database monitoring, right? So we watch every single database in our network. Well, that's the plan, not yet. We're implementing, so we're 30% of the way there. But I can see what happens inside of those databases. So if a rogue DBA that works for Cerner, is doing something that he shouldn't, I'll catch him, right? If somebody breaks into the network somewhere and is suddenly siphoning data out of a client database, I'll see that and be able to react to it. Security is about visibility largely, right? If I can see what's going on, then I can react to it. So it's having the right technologies in place and the right expertise on your staff to go investigate those problems. I mean, again, it's really fundamental. It's just fundamentals. It's patching. It's proper care and feeding of your environment and making the right investments. And it's really about how security people like me, I don't like to be called one, communicate those issues to leadership to get the right investments. That's one of the biggest challenges. And I said in the panel before this, and they were talking about how do you grow your career in cybersecurity, essentially. And one of the ladies on the panel mentioned communication skills, right? I mean, that's the key. Can you translate, Heartbleed, Bash, Flash vulnerability, Windows, 0-day, all these different things that are going on in the environment? Can I translate that into risk to the business or to our clients? And if I'm successful doing that, then I'm going to be a lot more successful protecting the data. And that's why we're making investments like database monitoring, which isn't, these things aren't cheap, right? I mean, the technologies are very expensive. A friend of mine at the Mayo Clinic, who's the director of risk management there, he says that hospitals are behind because, and this is paraphrasing his quote, but hospitals are behind because we have, naively believed the Red Cross protection, right? So likening it to a battlefield, is someone really going to take a shot at the guy with the Red Cross on his arm? And now we're playing catch up.
I'll answer it a little bit too, so I'll jump in if you've got a minute. But the most important information that you have is your name, address, social date of birth, and mother's maiden name. With those components, I am you. So the other information is noise to me. So credit card numbers, loan, anything like that, it's noise. I don't need that. So the other thing to Gary's point is hackers are looking for vulnerabilities. They'll find it in a system. So, and what they do is once they find that point, they'll pivot to other systems within the environment. So they just need that launching pad. And I think one of the speakers this morning indicated, and we've said it today, is, there's those that have been hacked and those that haven't been. I think it's really those that have been hacked and those that don't know it yet. It's really, they're not aware of it. And I think there was a speaker on the educational panel from Mandiant, or FireEye, who partnered with Mandiant. There's a gentleman there by the name of Richard Betchlich, and I'm butchering his name, but he's a graduate of the Air Force Academy in the 90s. He created the concept of extrusion detection. So if you watch the traffic as it leaves your infrastructure, if you monitor what's going on in the environment, I don't know that you need to get into the database monitoring so much, but if you just watch what's going out, you can start to determine what problems are occurring in your infrastructure, and you can trace that back to the source, to that original pivot point. So, and I think that's a key part, because if you look at what's happened to Target, Staples, and these others, who's reported that? DHS has told the companies that they've had a problem. As a former banker, that's horribly embarrassing. You know, I should know what's happening in the environment. I should be the one doing the reporting. So I just, you know, when I read that, it's scary to me that you don't know, these companies don't know what's happening in their environment. So, but Richard's website, I'm just going to plug this for a second, is Dow Security Blog, and it's a fantastic read. So he's a former Air Force intelligence, and he in my mind is a security geek. He's brilliant in this space. So. I'm done editorializing for a second. But
we're going to take one last question.
Henry Wilson, U.S. Army. I spent 8 years in the medical field and then 3 years in intelligence now. Most of my question was already answered, but there's another part that I was wondering about. The military has been moving along with healthcare to more of electronic, and obviously there's more vulnerabilities in that sense. And we've just addressed the security from the medical side. But what about the healthcare workers, healthcare personnel? What platforms are we using to help educate them, to help us as the security side of the house find those intrusions, look for that information, see what they can do?
I'm not aware of any, so I think that might have been your point. But I think that's an important piece, is that each one of us as users needs to be aware of the part that we play. I'm sure that we do our information assurance training every year, and we learn not to respond to phishing emails and all of this sort of general hygiene for how to be a good computer user. But on the healthcare side, we don't talk about that and the implications of not sharing passwords, but allowing other people access to the computer when you've logged on, and how you access patient records and those types of things. So I think we do it a little bit, but not like we should.
Yeah, security awareness programs, I mean, again, it's back to fundamentals, right? We didn't have one 3 years ago when I took over security. I established one. We started the annual training, which seems like the no-brainer. We did monthly newsletters. We do capture the flag contests in our development community, and provide some pretty substantial prizes out there. And we've really gone a long way towards improving our awareness. We do internal trade shows and do gimmicks to attract people over to the security table. It's been phenomenally successful, and it's really not a huge investment. And we saw infections go down by 3,000% in about a 6-month period after we started just getting in our associates' faces about security and what not to do.